Hi, this is Heather Wilson. Today I'll be giving my presentation for Maryville University in Integration of Mental Health Services in a Rural Primary Care Setting. First, let me introduce my committee. My DMP chair is Dr. Maria Snell. My second reader is Dr. Rita Wunderlich, and my community member is Rochelle Guess. When looking at the background and significance of mental health, it has to be understood that mental health services are sought throughout all regions of the United States, as mental illness can be present in anyone regardless of acquired or inherited traits. There's a vast spectrum of symptoms that can be present in mental illness that can present to healthcare providers and treatments that are needed to improve patient conditions. However, there is also noted to be disparities in these services in many parts of the United States. This necessitates an emphasis to improve integration of mental health services within a primary care setting. As a psychiatric mental health nurse practitioner in a rural north central Iowa area, there's a notable amount of mental health deficiencies in the primary healthcare setting and other outpatient settings. This integration of services should include prescriptive and non-prescriptive availability for all patients in need of these services. The work to complete this assimilation will include evaluating barriers to care and overcoming areas that display stagnation to mental health services. This project will be a practice improvement project, but will also involve components of quality improvement based on findings. The quality improvement will be ongoing work of multidisciplinary team to provide better care as a goal, improve patient outcomes, and then to promote professional growth among healthcare teams. The outcome will serve as a practice improvement project to verify effectiveness of incorporated services. It will be utilized to improve the organizational services and increase understanding in the practice. Approximately 40% of primary care patients needing mental health services find that providers are having a difficult time to meet their needs in the primary care setting. Within the primary care setting, it's also suggested that healthcare barriers to providing mental health services means that these quality services are unavailable or challenging referral processes, initiating low rates of appointments once the appointment's made, and communication between the primary care provider and the mental health care providers. These can be impaired by confidentiality, time, legal concerns, practice habits. Evidence shows that 50 to 90% of failure in outpatient referrals from primary care offices to mental health providers to even schedule appointment, but also a large percentage of that is also to even initiate the care once they do make the appointment. The possibility of changes from this project includes increased access to care in a local setting that accepts all forms of insurance, internal referral processes, instant initiation with meeting providers whom you'll be receiving care with, and increased communication between the primary care provider and the mental health provider sharing the same physical space in a clinic. So, in reviewing of literature, there are several different things that we're seeing. First of all, there were many barriers that were identified. They were broke down into three different areas: availability, accessibility, and acceptability. In the availability, there are shortages in providers and the resources within the community, or the financial means to pay for the care, such as being underinsured or uninsured. This barrier exists within the structure of clinics and communities that needs improvement. Support of a mental health service inside primary care in a rural healthcare would initiate growth and advocate for these patients' needs. Accessibility is the difficulties that can include transportation issues, increased likelihood of poverty in rural areas, longer travel distances to be able to get to these clinics that are further away, inadequate insurance or lack of insurance, perhaps financial concerns, employment barriers, having to miss work to be able to travel to these places to receive care, seasonal weather. In Iowa, we have seasonal weather that might prevent patients from being able to get care. Unsafe housing seen in rural areas is higher, and lack of public transportation. Facilities that are closer to rural areas may be beneficial for the barriers related to travel. Utilization of rural healthcare clinics also serves populations that utilize public insurance or may have other resources available to meet the needs identified. Acceptability includes the stigma of mental health, which is always present. Although we try to decrease it, it's still there. And this can affect care seeking from the patient that needs to be treated. Commonly acceptability barriers in rural areas have been shown as stoicism, distrust, meaning, anonymity concerns, as we know everybody in the area, and even technology used to provide cares, such as telehealth. The integration of services that has been seen throughout literature are services that are already being established and what's been working. Things such as warm handoffs, being able to show the patient who they're going to be seeing and introduce them that same day. Having same-day services. Patients that are especially in a crisis would be able to see a provider immediately. The flexibility with scheduling. The terminology that's being used. Electronic medical records, being able to share that plan of care between providers. When looking at the benefits to the patients, we're looking at promoting that access to care, being able to improve the communication between the primary care and the mental health provider. This can also lead to cost savings to healthcare, as many times urgent or emergency rooms are being used for mental health crisis or treatments when it could be done in an outpatient setting. When looking at theoretical framework, I chose Hildegard Paplau. She is a mental health nurse and was considered the founder of the psychiatric mental health nurse theory that is still used today of interpersonal psychology. Within this, she practiced that psychology and psychiatric nursing with the understanding that nurses can take on various roles in the relationship they have with their patients. This includes a stranger, a resource person, a teacher, a leader, a surrogate, and a counselor. She encouraged emotions within the nurse that would enable verbal and nonverbal communications with the patient, including self-awareness that's incorporated into the understanding that would assist patients to recognize their own problems. Within interpersonal psychology, she has 4 phases. The first phase is orientation. This is the first interaction between the nurse and the patient. The nurse will make observations and the patient also, and begins to build the trust and the rapport as the patient, though, is the primary focus. The next phase is identification. This is when the nurse can help the patient understand their needs and allow the nurse to understand their own needs within that relationship with the patient. Exploration phase is the pinnacle. Exploitation phase is the pinnacle of the nurse and patient relationship. The patient and nurse navigate their therapeutic relationship and interactions with activities to reach the goals that have been identified. The patient begins to take more and more control and be able to reach their goals with less assistance. The final phase is the resolution. The resolution phase is when the patient's goals and needs have been met and the nurse-patient relationship is terminated. Paplau also identified that patients want a connectedness that helps them the management of their emotions. Paplau's theory for nursing allows patient-directed care and independence as a goal to work towards in the management of their mental and physical health. This framework provides care in mental health while promoting whole health care at the same level. This is essential to the integration of mental health care services in the primary care setting, which is why I chose her theoretical framework for the collaboration of different multidisciplinary healthcare fields and the roles we play. When looking at methods of design, the first thing is to figure what setting to use. The setting chose was a North Central Iowa Rural Primary Care Clinic, that already had integrated mental health providers within its setting. It is a quantitative exploratory design through retrospective chart review. There was a utilization of electronic medical records for data collection with potential patient identifiers being removed for confidentiality. The first step is also to assess what the current practice is. The PHQ-9 is used in this facility, and it's completed yearly or as needed. If a patient is seen to need mental health services, it was a verbal recommendation to make an appointment to mental health on their way out. The intervention was then to provide education to providers and nursing staff regarding the PHQ-9, as it is a screening tool and when it is used for depression screenings. It's also what the scoring system means within it. Education was also given to providers, nursing staff, and front office staff regarding the placement of internal referrals through the EMR to the mental health care provider. This also included what to place into the patient's information on who they need to see, whether it be a medication management type appointment or therapy. So for the implementation of change, we look at identifying who had elevated PHQ-9s by the clinic and if the internal referrals were placed appropriately with patients making follow-up appointments and attending said appointments. The sample size included ages 18 years and older, patients that were seen in the selected rural primary care clinic, anybody in that category with elevated PHQ-9 scores between 15 and 21, and all genders. There were no previous processes for referral in place for elevated PHQ-9 scores prior to the intervention. After education was provided to the providers, nursing, and office staff, 5 referrals were placed. The information received indicated the ability to follow up with patients utilizing the EMR referrals to monitor adherence to the plan of care. These were also monitored by the front office staff who would review their work queue in the EMR and follow up with the patients that needed appointments. Originally, the data was to be analyzed using IBM SPSS program if there was 154 charts utilized in the sample size. This project is quantitative, and the research question is asking for a difference in outcomes. It is looking to complete understanding of the answer obtained as a quality improvement and a process improvement. Due to the comparison of information, a chi-square test would be completed with 2 or less independent variables, as it is a pre- and post-test design. The research subjects for the scholarly project included 16 primary care patients. This was the sample size evaluated pre-intervention with elevated PHQ-9 scores of greater than 14 of 9, and the sample size of those post-intervention with elevated PHQ scores greater than 14 was a number of 7. The facilitators to this included no modifications to the interventions that were originally in place. There were a couple barriers, including the 1-month period of intervention had decreased number of patients seen for wellness visits related to COVID-19 or respiratory illness. Due to policy, patients who were exhibiting COVID-19 or respiratory illness were not allowed to come into the well part of the clinic for wellness checks. This was at the height of COVID-19 in November with outbreaks and respiratory illnesses. Another barrier includes possible staff and provider error. Staff not recognizing that they need to complete the PHQ-9 at the wellness visit, or provider error in placing orders for referral to mental health services. When looking at results, you can see pre-intervention, 0 referrals were made, and pre-intervention, there were 6 patients that attended their appointments in mental health. Post-intervention, there were 5 referrals made, and post-intervention, there were 5 patients who did make appointments and attend their appointment in mental health. So, with the inability to do statistical analysis on this project related to the low number of sample size, it's a good opportunity to look at the data that is resulted and be able to tell the story of what is seen. With the review of charts with pre-intervention, 37.5%, and post-intervention, 31.3%, of the patients who were seen in the mental health clinic. Over half the patients were women at 81.3%, and these were pretty equal pre and post intervention. The mean of the age pre-intervention was 37.2 years of age, and post-intervention was 28 years of age. The range present was 43 to 47 years, with the youngest being 19 and the oldest being 66. The majority of patients also were seen at 68.8%, having a history of depression prior to this project being initiated. Most insurance was public at 56.3%, and private insurance was the second highest at 37.5%. One patient had no insurance coverage. Over half the occupations were non-agricultural based, and they were 66.7%, with only a small portion being unemployed at 33.3%. No agricultural-based occupations were identified in this data, which is surprising as we're a very high agricultural-based occupation rural area. And again, unfortunately, due to the small sample size of participants, there was no statistical analysis that could be done. However, we are able to see that the male population was under-supported, and those without insurance might be another barrier to be continued evaluation. The limitations, of course, with this project was the small sample size. This did not allow us to prove that the idea of integrating the mental health within the same clinic utilizing internal referrals was beneficial. The provider error could also be a limitation. Primary care providers also treat depression. If patients were identified with depression, it could be the primary care providers comfortable with treating the depression within that setting. Also, again, the decreased number of visits during this time for wellness checks due to COVID or respiratory related symptoms. In the discussion, they identify part of the demographics that are being underserved. For instance, the males, those who have agricultural related jobs or low ability for paying for appointments or no insurance, still identify that we have areas to be served and barriers that need to be overcome in rural mental health treatment. In healthcare policy, we're looking at increased satisfaction of consumers, being able to receive the care in a familiar setting, lower healthcare costs, being able to complete cares for mental health in outpatient settings versus urgent or emergency room, or decreasing silo type care where you have primary care and mental health services that aren't communicating, and this would actually break down those barriers so the plan of care can be throughout their whole health care. When looking at quality and safety, it's understanding the appropriate tools and resources. For example, the PHQ-9, being able to adequately use that when needed, decreasing the number of mistreatment opportunities, patients who are lost through the cracks by telling them to make an appointment on the way out. This would be an availability to keep them in the flow of making appointments and getting them the services they need. When looking at implications for practice, there's the consistency of the referrals that continue to identify those barriers that we continue to run into. Being a rural healthcare community, we want to be able to break through those barriers and provide services to everyone. In continued tracking of identification of the barriers and being able to make sure that the patients are following up appropriately, and being able to focus on the positive outcomes when we do have the co-managed care. In conclusion, ensuring that those that are needing such services receive the opportunity to follow up with their depression is essential to their well-being. Breaking barriers also exist and will take time and effort by all those involved. Successful integration of mental health services in primary care settings by the identification of elevated PHQ-9 scores and the appropriate referral process in the already present mental health services can help accomplish the goal of getting that whole approach to the patient's care. Continued use of the mental health services that are integrated can also close the gap on understanding the patient's follow-up and plan of care by primary care and the patient as they develop their treatment plans. Focus can also be given on those who are underserved based on the absence of the demographic data. And again, that whole approach to the person's care. This DNP project and program has brought to my attention in our area things that still need worked on as far as our integrated clinic. For future referrals, being able to track when patients have needed to see mental health providers may show increased need for mental health providers to be incorporated into the setting to meet those needs. I think if I continue to do review of this project, I would say over a longer period of time might give me the data I need to prove that it is beneficial. Any questions at this time? Here are my references. And again, I thank you so much for listening to this presentation.